Cutaneous melanoma is a very common type of malignant skin cancer. Today we are going to explore its epidemiology, genetics, risk factors, pathophysiology, clinical presentation, ABCDE, diagnostic criteria, staging, prevention, and treatment. Watch our non-melanoma skin cancers explanation from the link in the description.
Imagine a highly specialized cell with branch-like arms. This is called a melanocyte. Its primary job in the body is actually quite simple. It makes pigment. This pigment is what gives our skin, our hair, and our eyes their unique color. But sometimes this perfectly normal process goes wrong. When these specific pigment-producing cells mutate, they can become malignant. When that happens, we call the resulting condition cutaneous melanoma. It is a very aggressive disease.
What's truly fascinating is that these cells don't originally start out in the skin. During human development, they actually begin in a central area. This area is called the neural crest. From the neural crest, they migrate outward. The vast majority of these cells eventually settle in the skin. That makes the skin the most common site for this disease. However, they also travel to other places. They go to the eyes, they go to the mucous membranes, the upper esophagus, and even the meninges. The meninges are the protective linings of the brain. But because most of these cells end up in the skin, we actually have a unique medical advantage. It allows us to physically see the disease early. We can detect it visually while it is still curable with a simple surgery. Now, let's look at the broader clinical picture. Melanoma is serious. It accounts for over 50% of all skin cancer deaths. But when we look at the data, we see something incredibly interesting. The overall incidence is actually rising. There were over 100,000 new cases in the United States in just one recent year. Yet, at the exact same time, mortality is decreasing. The number of deaths is dropping by about 7% every single year. This is a direct result of incredible new treatments. We also need to carefully observe the racial disparities. White populations have a much higher incidence rate. It is 27.2 cases per 100,000 people. For Hispanic populations, that number is 4.5. For Black populations, it is 1.1. But we must note a critical fact here. In non-white populations, these melanomas frequently appear in hidden areas. They show up on the palms of the hands, the soles of the feet, or right under the nail beds. Because they are hidden, they are frequently discovered much later. This means they are diagnosed at higher, much more dangerous stages.
Understanding a patient's individual risk is absolutely essential. Imagine this risk like stacking layers of danger. The very first outermost layer is vulnerability to sun damage. This includes having light or red hair. It includes fair skin. It also includes a history of bad childhood sunburns or having prior skin cancers. The next layer involves melanocytic abnormalities. This simply means a patient has a very high number of moles, or it means their moles are large and unusual looking. Another severe external factor is immunosuppression. If a patient has a weakened immune system, their danger increases significantly. Now, let's consider the core internal risks. If a patient has already had melanoma, their risk of getting it again multiplies by 8 to 13 times. And if they carry a specific genetic mutation called CDKN2A, their risk skyrockets. It increases by up to 28 times.
We just mentioned genetics, so let's break that down. Up to 60% of hereditary melanoma risk is driven by specific known genes. For high-risk or high-penetrance genes, the most prominent one is CDKN2A. It sits on chromosome 9. This one gene accounts for 20 to 40% of all hereditary cases. Carrying this mutation creates severe biological vulnerability. Then we have moderate-risk genes. A really fascinating example is the MC1R gene. This is the exact gene that gives someone red hair, light skin, and freckles. It drives melanoma risk in two totally different ways. First, the light skin fails to act as an adequate shield against the sun's ultraviolet rays. But second, the gene itself causes oxidative damage inside the cells. This internal damage happens completely independent of the sun.
Knowing all these profound genetic risks, how do we actually protect patients? We use something called the split shield concept. Think of it as a defense with two halves. One half of the shield represents primary, environmental prevention. This means actively avoiding the sun early in childhood. It involves using physical blockers, specifically using sunscreens that contain zinc oxide and titanium dioxide. It also means making behavioral changes, like completely avoiding artificial tanning beds. The other half of the shield represents secondary, clinical surveillance. This is a very strict protocol. For patients with high risk, unusual moles, or a personal history of the disease, this is mandatory. It requires a full-body skin exam by a trained dermatologist. So, one side of the shield blocks the environmental damage. The other side actively catches any cellular changes as early as humanly possible.
When doctors and patients are performing that visual surveillance, they use the ABCDE diagnostic guide. Let's walk through these visual warning signs very slowly. A stands for asymmetry. If you draw an imaginary line through the middle of a spot, one half does not match the other. B stands for border. The edges of the spot are not smooth. Instead, they look irregular, scalloped, or poorly defined. C stands for color. A dangerous spot often has color variation. This means it displays unpredictable shades of brown, black, white, red, or even blue. D stands for diameter. We become very concerned when a spot is larger than 6 millimeters. For reference, that's about the size of a standard pencil eraser. Finally, E stands for evolving. This is perhaps the most urgent warning sign of all. It means the spot is visibly changing. Its size, its shape, or its color is shifting over time.
If a patient does notice an evolving, suspicious spot, they enter a highly logical diagnostic journey. Step 1 is clinical evaluation. The doctor uses a specialized handheld instrument called a dermatoscope. This tool provides low-level magnification using polarized light. It allows the physician to actually look beneath the surface of the skin. They are looking for specific pigment patterns. If those patterns show signs of cancer, we move to step 2. Step 2 is the biopsy. This is the absolute gold standard for diagnosis. The doctor performs a narrow-margin excisional biopsy. They surgically remove the spot along with a tiny 1 to 3 millimeter border of normal skin. This careful cutting preserves the architecture of the cells. Finally, step 3 is the pathology report. An expert examines that tissue under a microscope. They measure the exact depth. They count how fast the cells are dividing, and they check for any surface ulceration.
That highly detailed pathology report will also classify the exact nature or subtype of the tumor. Some subtypes, like superficial spreading and lentigo maligna, feature what we call a radial growth phase. This simply means they spread outward, flat across the surface of the skin. Nodular melanoma, however, is completely different. It lacks that outward spreading phase entirely. Instead, it only grows vertically. It plunges deeply into the tissues very early on, making it incredibly aggressive. Then we have acral lentiginous. This is the subtype we discussed earlier, the one that occurs on palms, soles, and nail beds. Finally, there's desmoplastic melanoma. This type is characterized by vertical and infiltrative growth. It frequently invades local nerve structures, and it has a very high rate of coming back to the exact same location.
So once we identified the tumor's visual structure and its genetic engine, we must determine its stage. Staging tells us the extent of the disease. We use the TNM system for this. Let's unpack this slowly. T stands for tumor stage. This is strictly defined by depth. The pathologist measures the exact microscopic distance the tumor has penetrated down into the skin. N stands for node stage. We have lymphatic vessels in our bodies that act like drainage highways. They lead directly to sentinel lymph nodes. We have to assess if cancer cells have traveled down those highways and parked inside these regional nodes. Lastly, M stands for metastasis. This is defined by distance spread. It means cancer cells have entered a blood vessel and traveled to distant organs, like the lungs or the liver.
For local disease, the absolute primary treatment is surgical excision. This surgery is guided by strict mathematical rules. The exact depth of the tumor directly determines the size of the safety margin. If the tumor is very thin, the surgeon removes a 1 centimeter border of healthy skin all around it. But if the tumor is deeply invasive, that margin doubles. The surgeon must remove a wider 2 centimeter border. At the same time, doctors calculate the mathematical probability of cancer hiding in the regional lymph nodes. If that risk is equal to or greater than 5%, the patient enters a specific protocol. The surgeon will actively offer and perform a sentinel lymph node biopsy.
Now, we must carefully consider what happens if that lymph node actually does contain cancer. This classifies the patient as having regional stage 3 disease. At this point, surgery alone is no longer enough. It must be followed by adjuvant systemic therapy. The goal here is to clean up any hidden microscopic cells. Modern medicine offers 2 distinct, highly advanced paths for this. One route is immunotherapy. This uses checkpoint blockade drugs to supercharge the patient's own immune system. The alternative is the genomic route. Remember that BRAF mutation we discussed? This targeted therapy path is exclusively reserved for patients whose tumors have that specific mutation. These drugs are designed to directly hunt down and shut off that mutated engine.
So, what steps do we take if the disease advances to stage 4? This is when it has spread to distant organs. Even in these highly complex scenarios, science offers incredibly precise interventions. One approach uses highly localized modalities, like pinpoint stereotactic radiosurgery. The goal here is to use radiation to target and destroy isolated tumors hidden inside organs like the liver or the brain. We aim for long-term survival even at this stage. Another truly fascinating approach is biological. It's called oncolytic virology. Scientists actually utilize a genetically engineered virus. A physician injects this virus directly into an accessible melanoma deposit. The virus replicates inside the cancer cells, completely destroying them locally. But more importantly, this localized destruction releases proteins. These proteins act like an alarm system, actively stimulating a massive systemic immune response throughout the patient's entire body.